So I want you to imagine going to the doctor in just absolute agonizing pelvic pain.
Right.
You're sitting there and you're given a diagnosis that ends in itis prostatitis. And, in the medical world and just in our general vocabulary, itis almost always implies an infection.
Yeah, exactly. It sounds like a standard bacterial thing.
Right. So naturally, you take these heavy-duty antibiotics for a month, you completely wreck your gut microbiome, you deal with all the terrible side effects, and then your doctor casually informs you that there were actually never any bacteria to begin with.
Which is just wild to think about.
It really is. You basically took a month of powerful drugs for an infection that literally did not exist.
Yeah, and the crazy thing is, for roughly 90% of men who walk out of a clinic with a prostatitis diagnosis, that scenario isn't, hypothetical. It's their exact lived reality.
90%? Wait, really?
90%? Yeah.
That statistic alone completely shattered my understanding of this entire condition. So, welcome to the deep dive, everyone. I'm really thrilled you're joining us today because we are tackling a mission that feels incredibly vital.
It really is.
We are exploring this complex ecosystem of independent medical information, patient education, and frankly, the severe consequences of getting it all wrong.
Because today we're looking at this fascinating foundational document from the editorial and medical research team over at an independent platform called iMedix.
Right.
And the document is titled The Pathogens of Prostatitis, a deep dive into bacterial causes.
And the mission today, for you listening, isn't just to answer the biological question of, what bacteria causes this condition.
No, not at all.
We're actually using this highly nuanced, deeply misunderstood medical condition to understand something much larger. We want to look at how independent platforms are stepping in to tackle medication safety, answer these really complex treatment questions, and fix the dangerous problem of real-world patient misunderstandings.
Yeah, because in our current era of just absolute information overload, understanding how medical safety is communicated to a patient is quite literally just as important as the medicine they're prescribed.
Wow, yeah.
I mean, the most perfectly engineered drug in the world is totally useless if the patient is too terrified of the warning label to actually swallow the pill,
Okay, let's unpack this right out of the gate, because I'm going to play the skeptic for a second.
Sure, go for it.
The source document really emphasizes that iMedix is an independent medical information platform, right? With a dedicated editorial and medical research team. But if I open my phone right now and type pelvic pain into a search bar, I am instantly hit with millions of results.
Oh, absolutely. It's overwhelming.
Right. Medical databases, clinic websites, forums, random supplement ads. Doesn't all this digital medical information eventually just blur together? Why does that word independent hold so much weight here?
Well, what's fascinating here is that it holds weight because the source of your medical info dictates the motive behind the info.
Okay, what do you mean by that?
Well, the typical search engine experience for a health query is heavily influenced by, search engine optimization, ad revenue, pharmaceutical marketing.
Everyone's basically trying to sell you something.
Exactly. It's like wandering through this crowded, noisy bazaar. But when we talk about an independent platform with a dedicated editorial team, we're defining a very specific boundary.
Like a quiet library, maybe.
Yes. A well-organized library with a dedicated librarian.
Yeah.
It means the raw medical data, like the clinical trials, the microbiological profiles, the FDA warning labels, it's all being actively vetted and translated without a financial mandate to push a specific treatment on you.
I see. So it's the difference between a pharmaceutical company, say, highlighting all the great benefits of their new antibiotic while burying the side effects in that tiny, unreadable font.
Right, the fine print.
Yeah, the fine print, versus a team whose only metric of success is whether the patient actually understands the biology of what is happening inside their own body.
That is the core of it. I mean, historically, if a patient wanted to understand the profound complexities of their diagnosis or the precise pharmacokinetics of their medication.
There's a medical textbook. Right?
Basically, they had to decipher the physician's desk reference. It was this enormous, dense volume written in an academic dialect of English designed for doctors, not lay people.
So it was essentially gatekeeping.
Intentional or not, yeah. It kept the patient entirely dependent on the, maybe 15 minutes they had in the examination room with their doctor.
And what caught my eye in this iMedix document is how far they're pushing back against that gatekeeping. Because they don't just write white papers or, maintain these text-heavy databases.
No, they're going much further.
Right, they're utilizing an official YouTube channel for outreach. They're taking this heavily vetted, independent medical research and turning it into digital audio and video.
Which represents just a fundamental shift in health literacy.
Yeah.
By utilizing video platforms, these independent teams are democratizing access to complex medical research.
Because it meets the patient where they are.
Exactly. When a patient is hit with a stressful diagnosis, handing them a dense printout of statistical probabilities often just spikes their anxiety.
Oh, absolutely. I'd panic.
But having a calm, knowledgeable voice visually break down the biology of their condition and the safety profile of their medication, that shifts the patient from a place of passive panic to, active participation in their own healthcare.
But I'm assuming the true test of a platform like that isn't just the format, right? Like the value has to be in how it handles the truly complicated, murky areas of medicine.
Oh, without a doubt.
Which brings us to the core case study provided in our source material. The text poses this central inquiry. What bacteria causes prostatitis? Now, on the surface, that sounds like a pub trivia question.
Right, you'd think the answer is just one specific bug.
Yeah, just one pathogen. But it's not that simple, is it?
Not at all. If we connect this to the bigger picture, the phrasing of their title is actually doing a massive amount of heavy lifting. The Pathogens of Prostatitis, a deep dive into bacterial causes.
Pathogens.
Plural.
Yes, plural. By using pathogens and causes, the source immediately confronts a fundamental medical reality that most patients miss, which is that prostatitis is not a single, uniform condition.
Okay.
It's an umbrella term for inflammation of the prostate gland. Identifying the precise biological cause is the absolute prerequisite for determining the right treatment.
Here's where it gets really interesting, because the source explicitly mandates exploring who may be affected and why. So we actually have to look at the anatomy and the different categories of this condition.
Right.
Because saying someone has prostatitis is almost as vague as saying someone has chest pain.
That's a great analogy.
I mean, chest pain could be heartburn from a spicy taco, or it could be a massive heart attack.
Exactly. And the medical community generally classifies prostatitis into 4 main categories.
Okay, let's stay the main.
First, you have acute bacterial prostatitis. Second is chronic bacterial prostatitis. Third is chronic pelvic pain syndrome, or CPPS, which we touched on earlier as being the non-bacterial one.
The 90% one, right. And the fourth is asymptomatic inflammatory prostatitis, which is usually just discovered by accident when a doctor is testing for something entirely different.
Like what?
Like elevated PSA levels during a routine screening, or maybe during an infertility workup.
Yeah.
The patient doesn't even feel it.
Okay, let's break those down sequentially, because the distinction between them really perfectly illustrates why a patient needs an independent medical platform to translate their diagnosis.
Absolutely.
Let's start with acute bacterial prostatitis. From what I understand, this is the least common type, but it is the most severe and, well, the easiest to spot.
Oh, it is entirely unmistakable. Acute bacterial prostatitis hits the patient with sudden, overwhelming force.
We're talking emergency room levels, right?
Yes. The patient will experience a high fever, severe chills, deep pelvic or perineal pain, and significant difficulty urinating, sometimes to the point of complete urinary retention.
Wow, so they can't pee at all.
Right. It is a severe, acute, systemic infection.
So this isn't just a nagging ache. This is a 5-alarm fire in the body.
Absolutely.
Yeah.
Because the prostate is highly vascularized, meaning it has a really rich blood supply, a severe bacterial infection there can easily spill over into the bloodstream.
Oh, wow.
And that leads to sepsis if it's not treated immediately. This requires swift medical intervention, often starting with intravenous antibiotics.
Okay, and what are the actual pathogens responsible for this massive biological fire? Because the source specifically asks, what bacteria causes this?
Well, the primary culprits are almost entirely the same bacteria that cause standard urinary tract infections.
Oh, really?
Yeah. Escherichia coli, or E. coli, is the dominant pathogen. It's responsible for a large majority of these acute cases.
Wait, E. coli, like the exact same bacteria that causes those national food recalls when it's found on romaine lettuce.
The very same genus and species, yes, though we are usually dealing with different strains here.
Okay, got it.
E. coli is a really fascinating organism. It's a gram-negative bacterium that naturally lives in the intestines of healthy people. In your gut, it's generally harmless, even beneficial.
Right, part of the microbiome.
Exactly. But it is an opportunistic pathogen. When it escapes the digestive tract and finds its way into the urinary tract, it becomes what we call uropathogenic E. coli, or UPEC.
But how does a bacteria migrate from the digestive tract all the way into the prostate gland? I mean, the anatomy there doesn't seem like a straight line.
Well, this is where we look at the routes of infection, which the source notes is critical for understanding who is affected and why.
Okay, paint me a picture.
So the prostate is a walnut-sized gland that sits directly beneath the bladder. The urethra, the tube that carries urine out of the body, runs straight through the center of the prostate.
Like a tunnel running through a mountain.
A very apt description. The most common route of infection is an ascending infection from the urethra. If bacteria from the gastrointestinal tract contaminate the urethral opening, they can travel upward.
But don't they get washed out when you pee?
You think so. But bacteria like E. coli don't just float passively. Uropathogenic strains have these tiny hair-like appendages called peli and fimbriae.
Pali and fimbria, okay.
Yes. They act like microscopic grappling hooks.
Wait, grappling hook, really?
Literally. They latch onto the cells lining the urinary tract, preventing the bacteria from being washed away by the downward flow of urine.
So they are actively climbing up the walls of the urethra against the current. That is terrifying.
It is. And as they climb, because the prostate gland surrounds that urethral tunnel, and because the prostatic ducts empty directly into that tunnel, the bacteria can basically flow backward into the prostate tissue itself.
Are there other ways for bacteria to breach the prostate, or is it always this urethral climbing?
There are other routes, though they're statistically much less common. There's hematogenous spread, which means bacteria from a severe infection somewhere else in the body travel through the bloodstream and seed themselves in the prostate.
Okay.
There can also be lymphatic spread from the nearby rectum, but the ascending urethral infection is by far the primary mechanism.
So E. coli is the main one. Any others?
Yeah, while E. coli is the chief offender, other common causative organisms include Klebsiella, Proteus, Enterobacter, and Pseudomonas. These are all classic uropathogens.
I'm noticing a pattern here. If the bacteria causing acute prostatitis are the exact same ones causing urinary tract infections, and they're moving through the exact same anatomical plumbing, wouldn't the symptoms overlap heavily?
Oh, entirely.
I mean, burning during urination, urgency, frequency, that just sounds like a standard bladder infection.
It does, and that overlap is a massive source of diagnostic confusion and patient misunderstanding. A man might develop these symptoms and just assume he has a standard, uncomplicated UTI.
And what happens then?
He might go to urgent care, get a basic 3-day course of antibiotics, and think the problem is completely solved. But because the bacteria have infiltrated the dense, spongy tissue of the prostate, a standard 3-day UTI treatment is entirely insufficient.
But why is the prostate so much harder to clear of bacteria than the bladder? If the antibiotic is circulating in your system, shouldn't it reach the prostate just as easily?
That's a great question. The prostate possesses a biological defense mechanism known as the blood-prostate barrier.
Kind of like the blood-brain barrier.
Very similar, yes.
Yeah.
The capillaries supplying the prostate are highly restrictive. Only certain types of molecules, specifically those that are highly lipid-soluble and unionized, can easily cross from the bloodstream into the prostatic fluid.
So most standard antibiotics just bounce right off.
Exactly. They just cannot penetrate the tissue at high enough concentrations to actually eradicate the bacteria.
Okay, so that covers acute bacterial prostatitis. It's a sudden, severe invasion by E. coli or similar bugs, and it requires immediate, highly tissue-penetrating antibiotics.
Correct.
But the second category was chronic bacterial prostatitis. How does that differ from the acute version?
Well, chronic bacterial prostatitis is a much more insidious, agonizing condition. It doesn't present with a 104-degree fever and a trip to the ER. Instead, it's characterized by recurrent urinary tract infections. The patient will have periods where they feel relatively normal, followed by a sudden flare-up of pelvic pain, burning urination, and maybe a low-grade fever.
So if the acute version is a raging house fire, the chronic version is like a smoldering fire in the walls that just keeps reigniting every time you think you've put it out.
That is exactly it. And the mechanism behind that reignition is one of the most fascinating aspects of microbiology. When bacteria like E. coli enter the prostatic ducts, they don't always just multiply freely in the fluid.
What do?
They can attach to the tissue and form what are called biofilms.
Biofilms. I've heard that term used in dentistry, like the plaque on your teeth. How does a biofilm work inside a human organ?
So a biofilm is a highly structured bacterial community. Once the E. coli attach to the prostatic ducts, they begin secreting a sticky protective substance.
Oh, yuck.
Yeah, it's called an extracellular polymeric substance, or EPS matrix. It's essentially a hydrogel armor that they build around themselves.
So they build a microscopic bunker.
They do. And this bunker provides incredible advantages for the pathogens. First, it physically blocks the body's immune cells, like your white blood cells, from reaching the bacteria.
Right.
Second, it is highly impermeable to most antibiotics. The drugs either get physically trapped in the sticky matrix or they're deactivated by enzymes the bacteria secrete into the gel.
Wait, if the antibiotics can't penetrate the biofilm, how does a patient ever get better?
This is where the real tragedy of chronic recurrence happens. When a patient with a biofilm infection takes a normal course of antibiotics, the drugs kill off all the free-floating active bacteria in the urine and the superficial layers of the prostate.
So the symptoms go away.
Exactly. The patient's symptoms completely disappear. They feel cured. The doctor thinks they are cured.
But the bunker is still there.
Deep inside the prostate, yes. The bacteria within the deeper layers of the biofilm have entered this dormant, slow-growing state.
And antibiotics don't work on dormant bacteria.
Right. Many antibiotics only work by targeting active cell division. Since these bacteria aren't dividing, the antibiotic basically ignores them.
Wow.
Weeks or months after the patient stops taking the medication, the environment becomes favorable again, the bacteria wake up, break out of the biofilm, and the infection returns with a vengeance.
I cannot imagine the psychological toll that must take on you. I mean, you go through the misery of the symptoms, you take the drugs, you celebrate feeling healthy again, and then 2 months later, the burning and the pain are just back? You must feel like you are losing your mind.
It creates immense medical anxiety. And what makes it even worse is that standard diagnostic testing often fails these patients completely.
How so?
Well, if a man goes to his doctor during one of those dormant periods between flare-ups and the doctor orders a standard midstream urinalysis,
The urine is going to come back totally clean because the bacteria are hiding inside the prostate, not floating in the bladder.
exactly. The lab culture will show zero bacterial growth. The doctor looks at the results and says, there's no infection. Your urine is sterile. The pain must be in your head or it's just stress.
Oh, that is so frustrating. And this highlights exactly why the source text stresses the necessity of an independent platform that explains the medical reasoning behind the issue.
Right.
If you are that patient and your doctor just dismissed you based on a standard urine test, you are completely lost.
But if that patient has access to the iMedix educational resources, they can read about biofilms. They can learn why clinical context matters so much.
They realize they're not crazy.
Exactly. They will learn about specialized diagnostic techniques like the Mears-Stamey 4-glass test or a pre- and post-prostatic massage urine culture.
Okay, explain that one. How does a prostatic massage change the culture results?
In order to prove the infection is housed in the prostate, the physician must physically massage the prostate gland through the rectum. This pressure forces the prostatic fluid, which contains those hidden bacteria, out of the ducts and into the urethra. The patient then provides a urine sample immediately afterward.
Ah, so that post-massage urine will catch the bacteria that were completely invisible on a standard midstream test.
Yes. So a patient armed with that knowledge from an independent database can go back to their clinic and specifically advocate for a post-massage culture.
That's huge. They aren't just a passive victim of a false negative anymore. They understand the mechanism of their own diagnosis.
And that level of patient empowerment becomes absolutely critical when we move to the third and vastly most common category, chronic pelvic pain syndrome, or CPPS.
Okay, this is the 90% statistic we open the show with, the non-bacterial form of prostatitis. I have to say, the fact that the medical community uses a word ending in itis for a condition that doesn't involve an infection seems like a massive communication failure.
It really is. It causes so much confusion.
If there are no bacteria, what is actually causing the patient's severe pelvic pain?
This is an area of intense, ongoing medical research. And it's why CPPS is designated as a syndrome rather than a singular disease.
Because the syndrome has multiple causes.
Right. The syndrome is a collection of symptoms with multiple potential underlying causes. In the case of CPPS, the current medical consensus points heavily toward a neuromusculoskeletal origin.
Neuromusculoskeletal, meaning nerves, muscles, and bones.
Primarily the muscles of the pelvic floor. The pelvic floor is this complex sling of muscles that supports the bladder, the prostate, and the rectum.
Okay.
In many patients with CPPS, these muscles enter a state of chronic involuntary spasm.
But what triggers the spasm if not a bacterial invasion?
It can be triggered by a multitude of factors. High-stress events can cause people to subconsciously clench their pelvic muscles.
Just like some people grind their teeth at night or carry tension in their shoulders.
Exactly. Over time, this constant clenching restricts blood flow to the tissue, a state called ischemia. The lack of oxygen and the buildup of metabolic waste in the muscles causes severe pain.
And the pain causes more stress, which causes more clenching,
Yeah.
creating a brutal feedback loop.
Precisely. In other cases, CPPS might be driven by localized nerve damage or an upregulated nervous system where the nerves are hypersensitive and just misfiring pain signals,
Wow.
or even an autoimmune response.
Hmm.
Interestingly, some cases of CPPS might actually begin with a genuine acute bacterial infection.
Wait, really? So it starts as an infection?
Sometimes, yes.
Oh.
But even after the antibiotics have completely eradicated the bacteria, the trauma of the infection leaves the local nerves and muscles in a chronic state of pain and tension.
Oh, I see. So the fire department put out the fire, but the alarm system short-circuited and won't stop ringing.
A very accurate way to visualize it. Now, consider the practical safety implications of this diagnostic confusion, which the iMedix source explicitly calls out as a priority.
Right, the safety implications.
If a patient with CPPS assumes their pain is caused by a persistent bacterial infection because of the word prostatitis,
Which they will because of the name.
right, and their doctor doesn't do the specialized post-massage cultures to confirm the absence of bacteria, what happens next?
The doctor prescribes antibiotics. And when the first round doesn't work, the patient goes back, complains of the exact same pain, and the doctor assumes they just need a stronger, longer course of antibiotics.
Exactly. We routinely see patients with CPPS who have been subjected to months, sometimes years, of repeated, heavy-duty, broad-spectrum antibiotic therapy,
For literally no reason.
trying to kill a pathogen that simply isn't there.
Which is a catastrophic scenario. I mean, not only is it totally useless for their pain, but they are obliterating their gut microbiome and exposing themselves to severe drug side effects for zero medical benefit.
And we can't forget, it also contributes heavily to the global crisis of antibiotic resistance.
Oh, right. Superbugs.
Right. When you flood the human body with broad-spectrum antibiotics, you are indiscriminately killing off susceptible bacteria everywhere in the gut, on the skin.
So only the strongest survive.
Yes. The few bacteria that naturally possess genetic mutations, allowing them to survive the drug, will multiply and take over. They can even share these resistance genes with other bacteria through a process called horizontal gene transfer.
That's terrifying.
By treating non-bacterial pelvic pain with antibiotics, we are unwittingly breeding multi-drug-resistant superbugs.
This perfectly highlights why clarifying the boundaries between infectious and non-infectious conditions is just the absolute bedrock of patient safety.
Totally.
Because if a patient understands they have CPPS, the entire treatment paradigm shifts. You aren't reaching for an antibiotic pill bottle anymore.
No, you're looking at completely different modalities.
Right. You're looking at physical therapy for the pelvic floor, alpha blockers to relax the smooth muscle tissue around the prostate, anti-inflammatory medications, or even cognitive behavioral therapy to help downregulate the nervous system's stress response.
Exactly. But, getting the diagnosis right is only the first hurdle.
Okay. What's the second?
Let's say our hypothetical patient actually does have chronic bacterial prostatitis. The doctor does the specialized culture, they find the E. coli hiding in the biofilm, and they determine that an extended course of targeted antibiotics is clinically necessary.
Okay, so they finally have the right diagnosis.
Right. The patient finally knows the exact biological cause. But as the source text emphasizes, getting the prescription is just the beginning of a whole new set of anxieties.
Because the next step is actually taking the medication. And the source text explicitly states that independent platforms must explore medication safety, explain real-world patient misunderstandings, and discuss practical safety implications alongside the regulatory or warning context.
Right.
I want to push you on this. Why are real-world patient misunderstandings such a massive focal point for a medical research team? Are patients really making that many catastrophic mistakes with their own prescriptions?
The rates of medication non-adherence and misunderstanding are staggeringly high. It is a massive public health failure. Oh, yeah. When a platform like iMedix talks about medication safety, they're not just analyzing the chemical bonds of the drug. They are analyzing the volatile intersection between pharmacology, a rigid regulatory system, and human psychology.
Break down that regulatory system for me, because the source specifically contrasts practical safety implications with regulatory or warning context.
Think about the physical experience of picking up a prescription from the pharmacy.
Okay.
Along with the pill bottle, you are handed a multi-page, densely printed leaflet. This document is filled with exhaustive medical jargon and lists every conceivable adverse event that occurred during the clinical trials, no matter how statistically rare.
Right, the leaflets that make you feel like you're signing away your life. You have a minor infection, but you read the paper and it warns you about, like, spontaneous blindness, liver failure, and hallucinations.
Exactly. The fundamental problem is that the leaflet is not designed to be an educational tool. It is a legal document.
Ah, to protect the company.
Yes. It is mandated by regulatory bodies like the FDA, and it is drafted by pharmaceutical lawyers. Its primary function is to prioritize exhaustive disclosure to shield the manufacturer from liability.
So it's covering their bases.
Right, but it offers zero context, zero empathy, and no practical guidance on how a patient should actually weigh the risks against the benefits of the treatment.
Which leaves the patient entirely unmoored. They are handed a legal waiver disguised as medical advice.
Let's apply this directly to our prostatitis case study. We established earlier that the prostate has a highly restrictive blood-prostate barrier, making it very difficult for most drugs to penetrate.
Right, they just bounce off.
Because of this, the medications required to eradicate a biofilm infection like chronic bacterial prostatitis must be highly tissue-penetrating, and they often must be taken for 4 to 6 weeks, sometimes longer.
6 weeks of continuous antibiotics. That is a really intense pharmacological load on the body.
It is. And historically, the most effective class of drugs for this specific task are fluoroquinolones, with ciprofloxacin being one of the most common.
Okay, ciprofloxacin, Cipro.
Right. Fluoroquinolones are incredibly potent. They work by inhibiting specific enzymes, DNA gyrase and topoisomerase V, that bacteria need to replicate their DNA.
So they stop them from multiplying.
Exactly. Without these enzymes, the bacteria cannot multiply and they die.
Yeah.
More importantly, fluoroquinolones are lipophilic enough to easily slip through the blood-prostate barrier and reach high concentrations in the prostatic fluid.
So they are basically the perfect weapon for this specific biological fortress.
From a purely pharmacokinetic standpoint, yes. However, fluoroquinolones carry significant risks. In recent years, regulatory agencies have mandated severe black box warnings for this entire class of drugs.
A black box warning. I know that term carries heavy weight in the medical field. What exactly does that mean for the patient?
It is the strictest, most severe warning the FDA can place on a prescription drug label. It literally appears inside a heavily bordered black box to draw immediate attention.
Wow. What does the box say?
For fluoroquinolones, the warnings highlight the risk of disabling and potentially irreversible serious adverse reactions.
Irreversible.
Yes. These include severe tendinitis and actual tendon rupture, most commonly the Achilles tendon. They also warn of peripheral neuropathy, which is permanent nerve damage, and central nervous system effects like severe anxiety, hallucinations, and suicidal ideation.
Wait. The mechanism behind a tendon rupturing from a pill you swallow sounds bizarre. How does an antibiotic designed to kill E. coli snap your Achilles tendon?
The exact mechanism is complex, but fluoroquinolones are thought to have a direct toxic effect on collagen fibers, and collagen is the main structural protein in our tendons.
Oh, I see.
They upregulate enzymes that degrade collagen and cause oxidative stress within the tendon tissue, weakening its structural integrity to the point where normal walking or climbing stairs can cause a complete tear.
Okay, put yourself in the shoes of a patient. You've been suffering from chronic pelvic pain for a year. You finally get a correct diagnosis of a bacterial biofilm. The doctor hands you a 6-week prescription for ciprofloxacin. You go home, you open the leaflet, and the first thing you see in a bold black box is a warning that your Achilles tendon might snap in half and your nerves might suffer permanent damage.
Yep.
What does a normal human being do in that situation?
They panic. The immediate psychological response is overwhelming medical anxiety. The patient stares at the pill bottle and attempts to mentally calculate an impossible equation. Is curing my pelvic pain worth the risk of being unable to walk?
And without any external context, without a mechanic to explain the check engine light, they're probably going to make a decision out of pure fear.
They do one of two things. They might completely refuse to take the medication, allowing the bacterial infection to worsen, potentially spreading to the kidneys or bloodstream.
Which is bad.
Very bad. Or, even more commonly, they compromise.
What do you mean compromise?
They take the medication for 5 or 6 days. The highly tissue-penetrating nature of the drug kills off the superficial bacteria quickly so their pelvic pain subsides.
Oh, no. I see where this is going.
They feel better, and out of fear of the black box warning, they immediately stop taking the pills.
But stopping at 6 days instead of 6 weeks means the biofilm wasn't eradicated. The deep persister cells are still alive.
And this is where their real-world misunderstanding becomes dangerous. The infection will inevitably return, but now The surviving bacteria have been exposed to a sublethal dose of the fluoroquinolone.
So they adapt.
They will adapt. The next time the patient has a flare-up, that E. coli might be completely resistant to ciprofloxacin. The patient's fear-based decision just turned a treatable infection into a multi-drug resistant nightmare.
This is exactly what the source means when it says platforms must explain practical safety implications alongside the regulatory warnings. A platform like iMedix acts as the translator here.
Absolutely. If a patient searches for ciprofloxacin on an independent, curated platform, they won't just be handed the black box warning in terrifying isolation.
Right.
The platform's editorial team provides the necessary context.
But how do they actually contextualize a warning that severe without downplaying the real danger? I mean, you can't just tell a patient, don't worry about your tendons.
No, you don't downplay it. You contextualize the statistics and provide actionable safety steps.
So give me an example.
The platform will explain why the drug was chosen, specifically noting its unique ability to cross the blood-prostate barrier when other, safer antibiotics cannot.
So the patient understands it's the right tool for the job.
Exactly. Then it will address the black box warning directly. It will explain that while tendon rupture is a severe consequence, the absolute statistical probability of it happening to a young, otherwise healthy man is actually quite low.
Okay.
However, the probability of the chronic bacterial infection destroying his quality of life without treatment is incredibly high.
So it grounds the fear in statistical reality.
Furthermore, it provides the practical safety implications. The educational resource will advise the patient to avoid strenuous physical exercise, heavy lifting, or high-impact sports while taking the medication and for several weeks afterward to protect their tendons.
That's incredibly practical.
And it will tell them exactly what early warning signs to look for, like a sudden aching in the heel, and instruct them to contact their doctor immediately if they feel it, rather than just silently stopping the drug.
It changes the entire paradigm. The patient moves from, this medicine is toxic, I refuse to take it, to this medicine is a powerful tool with known risks. I understand why I need it for 6 full weeks, and I know exactly how to modify my behavior to minimize the risk.
That contextual understanding is the singular difference between a successful cure and a catastrophic treatment failure.
So administratively, how does an independent platform actually manage and deliver this nuanced contextual information? We've talked extensively about the editorial team and the deep dive into bacterial biology, but mechanically, how is this data structured for the end user?
The source text explicitly emphasizes the iMedix drug database and educational resources as the primary tools for addressing these treatment questions and ensuring patient safety.
I want to look closely at those two terms, drug database and educational resources, because they sound like they might be the same thing, but in practice, they serve two entirely different complementary functions, don't they?
They are completely distinct layers of information architecture.
Okay, explain the database side first.
A drug database is the foundation. It is a rigid, highly structured, factual repository of pharmacological data. If you look at the back end of a drug database, you are looking at chemical structures, molecular weights, half-lives, metabolic pathways in the liver, known enzyme interactions.
All the hard science.
And the precise, legally mandated wording of every regulatory warning.
So it's the raw code. It's the dictionary. It has every word, every definition, and every rule of grammar. But handing a terrified patient a medical dictionary at 2 a.m. when they are agonizing over a side effect isn't going to help them.
Exactly. The database alone is too stark, too clinical. It lacks humanity. This is where the educational resources layer becomes vital.
Okay, so that's the second piece.
The educational layer is the translation engine built by the editorial and medical research team. It wraps around the rigid data architecture and makes it empathetic and usable.
How does that interaction between the database and the educational layer look in practice?
Let's say the drug database flags a severe drug interaction. For example, if a patient is taking ciprofloxacin for their prostatitis, and they also take an over-the-counter antacid containing magnesium or aluminum.
Like just a standard heartburn pill.
Yeah. The raw data will show that the metal ions in the antacid chelate or bind to the fluoroquinolone molecule in the gastrointestinal tract, preventing the body from absorbing the antibiotic.
So the antacid basically turns the antibiotic into an inert rock that just passes right through you.
Yes. The rigid database simply flags the interaction. Decreased absorption. Contraindicated.
Which a patient might not even understand.
Right. But the educational resource layer translates that flag into patient-centered guidance. It will say, If you take an antacid within 2 hours of taking your antibiotic, your body will not absorb the medication, and your prostate infection will not be cured. Please schedule your doses at least 4 hours apart.
It takes the what from the database and provides the how and why through the educational team. Knowing that resources like this exist is incredibly empowering.
Absolutely.
Instead of desperately scrolling through anonymous forums hoping someone else had the same symptoms, patients have access to an architecture of understanding.
And if we extrapolate on the future of this kind of integrated medical information, the global implications are massive. Misunderstandings happen in the void where data lacks context, or where context lacks accurate data.
Right.
By seamlessly merging a professional-grade drug database with a dedicated, independent editorial layer, platforms like iMedix are actively dismantling that void.
If every patient had this level of access and translation, we wouldn't just see a reduction in individual anxiety. We would see a systemic drop in hospital readmissions.
We really would.
We'd see a decrease in the rampant misuse of antibiotics for non-bacterial pain syndromes like CPPS, which directly combats the global threat of antibiotic resistance.
The democratization of a professional-grade drug database fundamentally alters the power dynamics of global healthcare. It takes the burden of absolute knowledge off the shoulders of the hurried physician and places a curated, understandable version of that knowledge directly into the hands of the patient.
I want to take a moment and connect this directly back to you listening right now, because it's really easy to get lost in the high-level talk of database architecture and biofilm structures and FDA warning labels.
That's a lot of data.
It is. But all of this ultimately boils down to your personal autonomy over your own body. These independent platforms exist for you. Whether you find yourself facing a complex, terrifying diagnosis with multiple potential bacterial causes like chronic prostatitis, or you are simply standing in the pharmacy aisle trying to decide which cold medication won't interact with your daily prescriptions.
Right.
Understanding how to utilize these educational tools makes you a vastly safer, more informed patient.
It transitions you from being a passenger in your healthcare journey to being an active co-pilot.
Yeah.
You are no longer just blindly following instructions printed on a sticker.
Yeah, you're beginning to understand the intricate mechanisms of your own biology and the specific tools modern medicine is using to heal it.
Exactly.
So let's take a breath and recap the massive amount of ground we've covered in this deep dive. We started with what appeared to be a simple binary question posed by the iMedix editorial team. What bacteria causes prostatitis?
But as we broke it down, we discovered a labyrinth of medical complexity.
We explored how prostatitis is not one monolithic disease, but a spectrum of conditions.
We examined the violent, sudden onset of acute bacterial prostatitis, driven primarily by uropathogenic E. coli climbing the urethra.
With their grappling hooks.
With their grappling hooks, yes. And we broke down the insidious recurrent nature of chronic bacterial prostatitis, where those same pathogens build microscopic, antibiotic-resistant biofilm bunkers deep inside the prostatic ducts.
And we confronted the shocking reality of chronic pelvic pain syndrome, the condition responsible for 90% of diagnoses, where patients endure years of severe pain and unnecessary antibiotic regimens for a neuromusculoskeletal condition that involves absolutely no bacteria at all.
We then transitioned from the biology of the pathogens to the psychology of the patient. We discussed the dangerous gap between regulatory warning labels designed purely for legal liability and the patient's desperate need for practical context.
And we saw how raw, uncontextualized fear of a black box warning can lead a patient to abandon unnecessary fluoroquinolone treatment, inadvertently creating multi-drug resistant superbugs.
And finally, we look at the structural solution. We explored how independent medical platforms combine the rigid, unyielding data of a drug database with the empathetic translation of an educational editorial team to guide patients safely through their treatment.
As we close out our analysis today, I want to leave you with a forward-looking thought about the trajectory of medical science and patient communication.
Because as independent, highly curated medical databases become more sophisticated and easier for the average person to access, whether through text, interactive platforms, or dedicated YouTube channels, we are rapidly moving toward an era where the traditional doctor-patient relationship must fundamentally evolve.
Historically, the physician held all the knowledge, right? And the patient was expected to simply receive it and comply.
But imagine walking into a clinic armed with the exact same understanding of pharmacokinetics, safety implications, and pathogen research as your physician. How does that level of knowledge change the conversation about your own body?
It stops being a monologue delivered by the doctor, and it becomes a collaborative dialogue. Because ultimately, navigating your own health should never feel like you are wandering alone through the dark, guessing at what might be broken.
Exactly.
With the right independent resources, you can clear the muddy waters of a diagnosis, read the biological signals accurately, and truly understand what is happening inside your own body. Thank you so much for joining us on this deep dive into medical literacy. Stay curious, stay informed, and stay empowered. Until next time.